we don't want to delay cancer treatment by too much, to allow people the time to think about it, but they do need the time to process it. We all need hope in some way to move forward in whatever direction. Allowing patients to take some control of their decisions is also a really hopeful thing. You know, it gives them some sort of power and some sort of autonomy over an experience, which is very distressing. And
hello, everyone. Nice to meet you again to a new edition of Beyond the Cancer Diagnosis interview series. Today it's my pleasure to have Michelle Peate, Associate Professor of University of Melbourne. Michelle, nice to meet you.
Nice to meet you. I'm well, and you?
Good. Today, together, we'll approach a very debated subjects nowadays about decision-making in psycho-oncology, and especially supporting patients in decision-making in psycho-oncology. It is a subject of many debates, with many understandings, with many definitions, due to cultural background of the, let's say, geographical area from we are talking about. To start our interview as an expert, what is your, let's say, interpretations? There is an official definition of decision-making. How is the process of taking these decisions when it comes to oncological treatment in any phase of
any phase? So I'll just start with a definition of decision-making then. So decision-making is, I guess, the cognitive and emotional process that people, so both patients and clinicians, engage in when they're making choices. And we're here talking about cancer care. And some decisions are easier than others. And the ones that I'm particularly interested in are the ones which we call complex decisions. So they're ones where there is no clear right or wrong answer. So you think about a lot of treatment. Yes, people need to make a decision about treatment, but often there's a path it's quite clear that that's the path you should take when it comes to treatment. Whereas, so in my area of interest in particular is oncofertility, and where we're talking about whether or not patients freeze some sort of reproductive material before they start their cancer treatment. And whether they do that or not, there's no right or wrong. What really comes into that is the personalized issues like values, your cultural background, your circumstances. Those are the things that will determine what path is the right path for you. So if we think about decision-making across all areas, what that typically involves is having good knowledge about the area, your choices, some sort of assessment of risks, what the benefits are, what your values are, and your preferences. And all of these things come together to determine what's the right choice for any individual.
Because I ask this because to take a decision in life, usually is the hard thing to do it. And especially when it comes to cancer treatment, at least you have to think twice before taking the let's say you can be sure that it's the correct one, but at least to be yourself, let's say, calm and relaxed that you took it the right one. But you mentioned oncofertility. Nowadays, we are living tremendous time of human evolutions, technology evolutions. Oncofertility comes as a consequences of all these developments nowadays. As far as I know, when we are talking about oncofertility, we are talking about like 3 different stages: pre-cancer, cancer, post-cancer, if I'm not mistaken. Could you please develop first what you mean by oncofertility, because this is the field, your main field of expertise, and each phase with its own characteristics, to put it this way.
So oncofertility is a field where obviously cancer and fertility intersect. So for a lot of cancer treatments or some types of cancer themselves, a common consequence of that is infertility. So for example, if you have a chemotherapy that includes an alkylating agent, so cyclophosphamide, for example, that has quite a high risk of infertility as a result of that treatment. Or if you have a surgery that involves removal of the ovaries or or the uterus, or some even brain cancers can have an impact on fertility. And obviously for men, it's around testes and you can affect radiotherapy can also affect semen production and egg production. So certain treatments can result in infertility. And for young people, so people who are still of reproductive age when they're diagnosed with cancer, this can have terrible long-term consequences. If you're thinking about an adolescent, for example, or a young person in their 20s, and if their treatment might render them infertile, you can imagine the psychological and psychosocial consequences once they recover. So things like how I've had patients say to me, how do I tell someone I'm dating that I can't have children? And what does that mean for my future? Or social expectations around being a parent in the future. So fortunately for what we can offer is usually fertility preservation. Now, there are some limits to that. Obviously, cancer treatment is a priority. So for me, cancer patients, if they're going to do something, they need to do it quite quickly, and they might only be able to do one IVF cycle, for example. So it doesn't guarantee them a future parenthood, but it gives them an option that they can try. Now, not everyone becomes infertile, so this could just be a nothing just in case, to have just in case for later. So you talked about, the 3 stages. So you can, pre-cancer is going to give you the best outcomes. And so ideally, if they can do something then before they're exposed to that toxic treatment, that's ideal. But there's a lot of pressure. You've just been diagnosed with cancer. Everyone wants to start the treatment. So it may not be realistic. Then obviously, while there are some treatments that can be done during cancer treatment, that sort of, in women in particular, there's some drugs that we can use to suppress hormones and might offer some protective effect. Guidelines do say that you should never do them as your only fertility preservation option. And there is also the option to try and pursue a fertility treatment after your cancer treatment is done. But again, these are I guess your body's been exposed to the cytotoxic drug, so the chances of them working might be a bit lower than if you've done it before. So when it comes to decision making, what we really ideally want to see is the decision making starts at the very earliest possible stage. So soon after diagnosis, patients should be told about their options, told about the potential impact their cancer treatment may have on their fertility, and then be given a referral options to talk about anything they might want to do now. But they should also be aware about the stuff that they can do during treatment and after treatment, because it's not the only option available to them. So we try and get in really early, recognize if a decision needs to be made. For some patients, they're not interested. Fertility, it's not something that worries them. For others, it's a really big issue. So recognize whether a decision needs to be made, give them their options, give them the evidence around their options, and then we try and support them in weighing up the pros and cons and deciding what's important to them. And obviously, I think around the world, we prioritize shared decision making. And that does involve patients talking with their clinician around the pros and cons and benefits of these treatments and trying to come up with something that is reasonable and what's the best choice for those individuals.
You mentioned an interesting fact. How do I say to a person that I'm dating that I can't have children? I'm not an expert in the field, but I remember now the words of great philosopher Nietzsche that said it's the lack of friendship, not the lack of love, that lead to breakups. So when we are talking about friendship, we are talking about communications. And if we are talking about communication, we are arriving to decision-making process. So I guess, in my view, that decision-making is a process to be learned. It's not something that majority of patients understand that it's a must. It's rather a process that they have to understand. rather than I have to take a decision. Because this is, I guess, it's a nuance, very important.
Yes, very important. It is a process. And, I sort of touched on it a bit, how first thing you should know that there's a decision, you've got to look at everything, decide what's right for you. But I guess you can always change your mind. I mean, some things, oncofertility is a little bit different in the sense that, yes, you can change your mind, but your success from the procedure changes with that if you change your mind later. So we do often talk about you can't go back in this decision and get the same outcomes. But it doesn't mean you can't change your mind later, for sure. And that's what some people do. And it is definitely a process, and it's, I guess what you'd expect is people take some time to think it through. There is time pressure in this particular, I guess this is why I find this area very interesting, because we don't want to delay cancer treatment by too much, to allow people the time to think about it, but they do need the time to process it, to actually be able to think about all of the aspects that it may affect them. So definitely is a process, definitely has lots of steps. And especially with this one, when we're talking about fertility preservation, we also have the end of that decision, which may be many, many years from now. So if you store some embryos or some tissue, ideally you want to get through all your cancer treatment. You probably, if you don't have a partner, find a partner or do it by yourself. But then eventually you come back, you go, well, what do I do with that tissue I've frozen? And that's another decision. So it's never just a one decision and it's the end. And I think that applies throughout all of cancer, the context of cancer, whether it's your treatment, you've got your follow-up, you've got all of that. There's just always multiple points along a decision pathway. We always talk about decision pathways because, yes, you're right, it's not just a moment. It's a process. And a core part of it, just coming back to what you're talking about, Adrian, is that communication, like really good communication with your clinical team, really good communication with the people who you care about and care about you, who your decision may affect as well. So yeah, communication. I mean, this is where it's really a big area in psycho-oncology because, that shared decision-making piece is really, really important. And I guess the other thought I have around that is that with shared decision-making, it's a process for the patient. It's also a process for the clinical team. And the quality of that process, I think, is a really strong predictor for psychological outcomes later. So if a patient feels really well supported and guided through it, there's going to be less regret. The decision will be easier for them. And this is where the team can really help support their patients through cancer care.
You mentioned the decision-making by the medical team. And what I want to ask you now, an interesting question. For the first time, let's say, you communicate the diagnosis, the patient have time to process, then to take a decision. Meanwhile, the medical team already took a decision. These two concepts are the same on the first phase, or after it will be let's say, not a debate, but on discussions on the best way to move forward.
Yeah, so it probably comes down to how the medical team functions in your setting. The ones that I've been fortunate enough to be able to observe, in the hospital I sit, in the different hospitals I've worked at, is we use a multidisciplinary team approach. So I guess the medical team will have a discussion and have a plan and a recommendation often, and they've all the different roles, whether it's the surgeon or the oncologist or the psychologist or the nursing team, they're all involved in that discussion. So I think what that means is when they come to treating the patient in the hospital, they come with almost like a united front. And this is for things where there's a clear path. And where there isn't, then the decision does largely be put on the patient and say, well, here are your options. And this is, but most patients will ask, what would you do? Or what do you recommend? And so it's always a good idea to have something there for that. But yes, I have through my research, seen cases where people are given different recommendations by different people, and that can be very confusing for them. And I guess in that scenario, a lot of my work is around decision tools. So this is where tools can be useful, where you can give patients tools and say, look, really, in this scenario, you're the only one who can really know what's right for you. Here's a tool that can help you make that decision. Given that you've been getting different, recommendations from different people. So I think it is avoidable. And to be fair, different clinicians will have different opinions. And we're allowed to do that. So I guess it's about having all the resources there to help our patients do what's right for them.
And fortunately or unfortunately, we have to take into account the caregivers. Because if we are talking about Eastern Europe area, the caregivers are, let's say, the leading persons in decision making. Sometimes not the patient. So this thing comes like a barrier in all this decision making process. And except caregivers and the communications issues, are there any other barriers in decision making process?
Yeah. Caregivers, we do a bit of work with our children with cancer, and that's a really interesting space because parents are the ones who make a decision, and you've got two often parents, and they may not agree. And so that can make it really complicated, but that's certainly a barrier. Other barriers, I guess, might be, I sort of talk about time constraints. So if you don't have enough time to make a really good decision and there's time pressure, certainly in Australia, we can have health literacy challenges. So, there's literacy in itself. We have quite a culturally diverse community. So maybe there are people whose English is not at the same level as, say, a native English speakers. So there's that. But there's also, even within native English speakers, I've learned a lot around just because you have good English skills doesn't mean you understand health information in your own language. So health literacy can make things difficult. I mean, I know from my own experience, when I go into hospital, sometimes I find the forms difficult to understand. And my health literacy, I think, is pretty good. So I can only imagine what it's like for others. In our oncofertility space, a particular barrier from a clinical perspective is the clinician discomfort. So I have a colleague of mine who always says that whenever she has to have the discussions with patients about oncofertility, she feels outside of her comfort zone. She's trained as an oncologist, not as a fertility specialist. So now she's trying to have these conversations, and it makes her uncomfortable because she doesn't feel like she's the expert in that. And I guess this is where you can call on your colleagues or multi-routines or referrals to try and address that. Cultural differences. So, different cultures value different things. So you, again, bring it back to oncofertility. Certain cultures, fertility is really important for identity and your value in society, or even perceptions of autonomy. Whose right is it to make this decision and stuff. In a cancer context, there's also the emotional burden. Patients are dealing with a lot, and the fear, I guess, of what a cancer diagnosis means. So there can be the emotional overload can impact cognitive processing, as we know. And I guess you can have, intent and buy-in and have clinicians who are on top of it and patients who are really driven to do something, but your system doesn't facilitate that. That's also a problem. So if you don't have integrated care, like some patients miss out, for example, on discussions because the care is not integrated. Or I talk about decision tools like that can help facilitate to make sure every patient is getting all the information they need and the supports. In Australia, we have a very, our population is quite spread out, but what we know that means is people who live in rural areas or outside of big cities often miss out on care because it's hard for them to access and they just don't have the facilities out there. So there's all the system level issues can also cause barriers to decision making because it's just, you just don't have things available or the processes aren't set up in the hospitals or in the clinics to support that. So I think, there's always going to be challenges. And there are going to be some centers that do a great job because they've got all of that built in, and then others will struggle a bit more. And that's why I believe there's value in trying to empower patients to advocate for themselves in these settings. That's it, recognizing the emotional overload, load. But, if they can at least insist. I remember when I started doing this working on fertility, I had a discussion with a woman who had breast cancer, and it was a cancer recurrence. She said to me, she goes, her initial experience wasn't great because she'd been diagnosed. She was about to get married, and and this was her second partner. She already had 2 children from her first relationship, and she and her partner had talked about co-parenting together. And she went to her oncologist and she said, look, I've heard that cancer my treatment can impact my fertility. I always plan to have at least another kid. What can we do? And the oncologist was very dismissive and sort of said, what are you worried about? You've already got 2 kids. You can be grateful for that and just focus on your cancer treatment. And of course, this really upset her. She was she then went and saw her surgeon, and her surgeon had a very different approach. And the surgeon actually raised it. Have you thought about this? And she's like, yeah, but this is my story. This is what the oncologist said. And so the surgeon was great and said, look, I'll refer you and you can have that discussion. But what was interesting about that, I think, was that barrier was the clinician was the barrier for that patient to be able to make that decision. And that in the end, they chose not to do any fertility preservation. But as she said to me, she goes, at least I had the chance to discuss it. She could go the option. She could talk to her partner. She could say, this is what potential outcomes are. This is what our chances are in the future. And then she could then go through it, having done everything that she thought was right at the time, or they thought was right at the time. To not then go and regret the decision later. Because I think fundamentally that would be a horrible experience. You get to the end and go, well, no one told me about this and I could have done something. So, it needs, and I think that she was able to advocate for herself to a certain extent. And I think that really helped. And if she hadn't, she probably wouldn't have any discussion about it. So I think if we can empower, obviously system level change is important, and that's something we can do as healthcare professionals. But I think we also need to empower individuals to be able to advocate for themselves in health systems as well.
You mentioned individuals to advocate for themselves, yes, and you talk about systems and so on. But what about the social pressure nowadays?
Oh, yeah. I don't know how we fix that one.
Because having a child today, at least from my experience, it's like a social pressure, and I don't know where it comes from, but what upsets me is I don't know where it goes. So from the oncofertility point of view, how do you see it?
Yeah.
In a way that they are, let's say, patients are coming due to a social pressures rather than the personal decisions, or it's a mix of trying to find my place in a new society, in a new community, and so on and so forth.
Yeah, so the fertility piece, separate from cancer, is that's the big question, is it? How much of it is social pressure and how much of it is a person's individual desire? And I do a bit of work outside of cancer around this as well. And look, I think that there is a lot of social pressure, undeniably, around becoming a parent. It's tied into identity. A lot of young children grow up with the expectation that they're going to be parents someday. And you're right, where does it come from? It probably comes from what you see on television and what you read in books and those sorts of things. And there are a lot of negative stereotypes that are tied to people who don't have children, especially in the olden days. I think that's shifting and changing. But even the labels we use, particularly for women who are, childless, or even the term childless, I've seen new terminology, say child-free, around. So there definitely is a lot of pressures, and some societies it's much stronger and heavier burden than others. And I think there needs to be a social shift around that. But that's I think that's a difficult thing to shift. Probably having more representations is seeing more I'm going to use the term child-free, but child-free people around the world, and people embracing that might help shift that. I think there's also maybe a lot of people don't realize what it really entails to be a parent. And I've just seen that in my own life experience with my friends, where sometimes people are quite shocked by how much effort and work it is to be a parent. So, but yeah, how do we sort of disentangle that? The only thing I can say is, again, if we try and make it an informed decision. So I once met a patient who actually was involved in one of the first trials I did around the oncofertility decision aid. And what I loved about that discussion I had with her was that she said to me, do you know what she loved about the tool? She loved that it made her feel okay with not doing fertility preservation. And so what I took from that, I mean, we showed that this decision aid actually improved decision-making outcomes, and it was, effective, which was great. And we could roll it out. But I think what her experience really highlighted to me is that you've got that flip side of sometimes people do feel a lot of pressure to do fertility preservation in the context of cancer because it's expected of them. And what this allowed them to do is take a step and go, actually, it's not right for me, so I'm not going to do it. And I'm okay with that. And that's probably something that can be applied more broadly. But yeah, it's about, again, making informed choices around even being a parent, making an informed choice about that, because it's probably not right for everyone. But I do think there are a lot of those social pressures kind of force people down that path without necessarily thinking through why. Like, why is it that you really want this? I don't know if that's answered your question, but it's a really big...
It's okay. Yes, I was referring at this point. And since we are approaching the end of the interview, I want to ask you one more question. Where is hope?
Where is hope?
In all this.
In all of this.
In all this that we've discussed so far.
Yeah. So look, I guess I have a belief that we all need hope in some way to move forward in whatever direction. And in fact, this was something, I can't remember the name of the person, but someone who's very, well respected in the oncofertility space actually said years ago, when they first recommended fertility preservation in cancer, that this was a good thing because it gave people hope. It gave them a way to think about life after cancer and not be so focused on their cancer treatment. But again, it needs to be an informed choice. We need to understand that there's no guarantees from this procedure. But at the same time, I think there is something about living beyond cancer and what that means. So from an oncofertility space, that's really hopeful. And in terms of the more broadly shared decision-making, I think allowing patients to take some control of their decisions is also a really hopeful thing. It gives them some sort of power and some sort of autonomy over an experience, which is very distressing. And, you have no control over the cancer itself, but it's great to be able to have some control over the decisions around it. And that can also give a sense of hopefulness, I guess.
Michelle, thank you very much for having you today. Good luck on your research further on this very interesting field of expertise, which
thank you.
I think it will be more and more interesting, to put it this way, like an elegant way, because we don't know what the future will bring us. So, as you mentioned, we have to keep it hope and to move forward. Thank you very much, and good luck further.
Thank you so much for having me.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.